we're at time. And thank you all for joining us. And my colleague, Bruce Pyenson, had insisted that we save the best for last. And so this is the final block of the workshop. And Bruce, you're leading this with Anita. Thank you, Anita. And do you want to introduce your guest and get underway?
Well, thank you very much, Jim. And I feel honored to not just be invited to be at the quantitative imaging workshop and surrounded by so many brilliant people who are taking care of patients and making the discoveries that are going to cure people and funding the discoveries. But the panel we have this afternoon, the panels we have this afternoon make me feel doubly honored to have individuals who are working on a day-to-day basis with the data and the targets for millions of lives to improve the healthcare that's delivered. And this is truly population health. It's key for the quality of healthcare delivery through the country. And I know there's lots of interest in the quality of imaging and the quality of diagnosis and outcomes. That's always part of the quantitative imaging workshop and Prevent Cancer's work. But this is as important, but on a grander scale of looking at outcomes and looking at processes that affect millions of lives. And the folks that we have today are going to address that. So we're going to have a roughly an hour of didactic teaching that goes through and explains how quality metrics are created and why they're so important, and how organizations like American Cancer Society or American Lung Association participate in those. And then we're going to have another hour of more open discussion to bring that to how does that actually make things happen at a health plan level. So just to introduce our speakers, we really, I want to thank all of our panelists for taking the time on a Friday afternoon, but I'm so pleased that we were able to get really the national leaders to address you. Mary Barton is going to go first. She's been in leadership at the National Committee for Quality Assurance, the NCQA, which is the giant organization in healthcare quality metrics. It is profoundly important. It's a solid and impressive engine that develops, updates, retires various metrics, and works with lots of other organizations to make sure they're right and to report that out. And it does that on a grand scale. And before that, she was with U.S. Preventive Services Task Force. Barry's going to be followed by Robert Smith, who's the cancer epidemiologist, has been at the American Cancer Society for a number of years. Bob was very active in American Cancer Society's efforts for mammography and colorectal cancer screening, and participated with NCQA in the development of those metrics and their implementation. And the last teaching session before we get into the discussion is Hannah Green, who's National Director of Health Policy for the American Lung Association, and recently has worked with NCQA on developing a metric for asthma in Medicaid plans. So really an amazing group of panelists here. I'm just going to say a little bit, and then we'll pass it over to the actual content. But health insurers spend or earn billions of dollars a year with better population metrics and outcomes. This is incredibly important for almost all insurers. Certainly very important for the federal Medicare program, which I like to say is the world's biggest health insurer. But health insurer involvement and the incentives, whether it's Medicare Advantage plans or plans on the exchange or Medicaid plans or employer plans, that promotion has led to more preventive care and better outcomes. So this is really the key driver of getting change and getting it implemented on a scale of tens of millions and hundreds of millions of lives. The examples of some of the STAR metrics are here. The STAR metrics are how Medicare rewards Medicare Advantage plans or Part D plans. There's 30 some that are in current use: breast cancer screening, colorectal cancer screening, flu vaccination, osteoporosis management in women who have had a fracture, and some for diabetes care. That's pulled out of a list, as I said, of over 30. So this is, again, incredibly important. It's on a vast scale, and the reporting that goes on an annual basis is an impressive task. So without further ado, I'm going to hand the virtual microphone over to Mary, who's and Richard, if you could take it away.
I'm Mary Barton. I'm Vice President for Performance Measurement at the National Committee for Quality Assurance. I'm here to tell you a little bit about what our organization is and how it works. And to do that, I'm going to explain a little bit about performance measures. So when we think about how value-based healthcare should work, we should be able to maintain people's health. So people who are already at low risk, keep them at low risk. And for folks who are exhibiting signs and symptoms of disease or who have chronic illnesses, that we could maintain their health, prevent them from getting worse. And so this idea is really in contrast to the sort of last century of American medicine, where we paid people fee for service, paid them the more they did. Here's an idea that says maybe we could pay people for value basis. We could pay them for getting people better. And performance measures are really an important part of this goal. Next, I'm going to tell you a little bit about the HEDIS measure set, which is what NCQA uses to determine the quality of healthcare that is provided by health plans, both Medicare Advantage plans and also commercial and Medicaid plans. So HEDIS stands for the Healthcare Effectiveness Data and Information Set. This measurement set is used by more than 90% of American health plans. It permits a comparison of health plans to each other across important dimensions of care. So we have measures that look to see if patients or members received preventive services, whether they had managed their chronic conditions managed. We have several measures that address behavioral health services. In addition, we have measures that look at coordination of care and then overuse or appropriateness of care. There is without a doubt, in the last 20 years, we've seen a positive trend towards accountable healthcare systems. So this shows the millions of members in health plans that report HEDIS data and audited HEDIS data. So that means that the plan's numbers are checked. And so, you know, back in the year 2000, there were maybe 50 million members in such plans. Now we have 191 million Americans in health plans that report HEDIS data. The most recent set of HEDIS measures include 92 measures across 6 domains. These are reported by all health plans that have that are accredited by NCQA, or health plans that have state requirements to report, or for example, all Medicare Advantage plans are required to report the HEDIS measures to NCQA. So when you think about the domains, we have here listed the effectiveness of care domain. That is really all of the things that have to do with high quality medical care. We have 5 measures in the access and availability of care domain. There are 3 measures that comes from the CAP survey about the experience of care. And then we have measures in the utilization, risk-adjusted utilization, and health plan descriptive information sets. And finally, measures collected using electronic clinical data systems. These are measures that take advantage of clinical data, whether it comes from EHRs or registries, and puts that together with information from other electronic sources such as claims data or health plan administrative data in order to report on quality at I would say, a finer layer of, a more finely detailed layer of quality than we could do with just claims data alone. Now, where are these HEDIS measures used? In addition to NCQA using these measures in our own accreditation programs, they're used by the Center for Medicare and Medicaid Services, CMS, has 10 measures of ours in their ACO program, 33 measures of ours in their quality payment program, which is the individual clinician program, 24 in their quality rating system, which they're going to be using to compare the marketplace plans to one another. 14 measures in CMS Part C star ratings, 10 in the Part C display, 17 measures in the Medicaid adult core set, and 12 in the Medicaid child core set. So HEDIS measures are widely used and really looked to determine quality of care. When we look at the 55 measures in the effectiveness of care set, here you can see a distribution of the sort of health categories that they're in. We have a lot of measures in the prevention and screening set, and then also respiratory, cardiovascular care, diabetes, behavioral health, I mentioned before, overuse and appropriateness. All of these categories include measures that aim to distinguish one health plan from another. I'm going to talk now a little bit about how we develop measures, because I think this is important to what this panel is going to be discussing. Whenever we create a measure, we're looking to make sure that it meets all of our desirable attributes, and that includes relevance, both to stakeholders, to potentially to patients, possibly to the financial impact of improvement. And also this implies that there needs to be substantial variation in care, because it wouldn't benefit you to measure something if everybody was already performing at 100%. Right? Scientific soundness, very important. This is making sure that our measures are based on the best evidence and the strongest guidelines, because we don't want to be encouraging care unless we feel confident that this is going to benefit the patients that are receiving that care. Processes are sometimes measured, or structural measures sometimes, but we look to make sure that those are linked to outcomes. So for example, there's lots of evidence about breast cancer screening. We have a measure that says, did patients get breast cancer screening? That's a process measure that looks that a process was performed, was done, but it's strongly linked to outcomes based on extensive research literature. We also, in the scientific soundness category, look to make sure that the data that is used to report the measure is reliable and accurate, and therefore the measure is valid. And then finally, feasibility is an important issue because we need to make sure that the measure is specified as precisely as it can be, that needed data is available to supply that measure, and that the cost of data collection is reasonable. Finally, I mentioned audited data. NCQA has an audit protocol that it uses to audit all health plans that report HEDIS data to us. And that audit is really a key part of what we mean when we say we have a performance measure. And so the ability to be audited is an important part of the feasibility of a performance measure. So I'm going to talk a teeny bit more now about data sources and data collection methods, because there is an evolving data landscape that we're in the midst of. The box above shows what traditionally HEDIS has used: administrative data, sometimes hybrid, what we call the hybrid method, which is when administrative data is used for part of the measure, but then a sample of medical records is pulled for the other part of the measure. And then finally, the survey method. I mentioned CAPS. We also have used in the past the Medicare Health Outcomes Survey to collect a health plan measure. I want to mention, though, on the right side of the box is what is called supplemental data. So when health plans have been reporting an administrative measure, they may have been including laboratory results or data from registries or other kinds of supplemental data to support the reporting of their measures. Our newest entry in the category of data collection methods is the electronic clinical data systems method. The reason that we designed this was that we knew that there were ways to use data that was standardized. The supplemental data has been kind of a thorn in the side of both health plans and auditors because of the difficulty in auditing it. And we knew that if we could line up the way that data comes into the health plan from registries or case management systems or claims, that they could bring that data together and report it in a standardized way. And so that is what the electronic clinical data systems method is it's a way for health plans to report digital quality measures that are expressed digitally and that are gathered digitally. And so that is really something that I can't give you enough detail about. If you want more, you can go to www.ncqa.org/ECDS to get all the information you might possibly want about this approach. The data collection methods are interesting in that they differ by both the denominator and then also the pros and cons of that method. So the denominator for administrative measures is typically the entire eligible population. The pros of this kind of measurement is that it's less expensive and less time consuming. However, a con is that it lacks clinical detail. Typically, there's really ability to understand anything else about the clinical situation that the patients are in. Hybrid measurement uses a systematic sample, and so that is has the potential to be more accurate as a way of describing healthcare provided to patients, but it's extremely resource intensive. So sending out these reviewers to do charts is really quite expensive. The survey measures use also a random sample, and it is to capture a patient perspective because you're asking the patient themselves to, to speak for themselves. But it is also expensive, and I will say that they feel that survey data is less actionable because you don't know who is the patient who had the bad experience. You have no way to intervene on a person level with them. Finally, the ECDS approach is a way then to use the entire population, the entire eligible population, and to capture clinical data that is efficient, an efficient approach, and is more actionable. However, health plan capabilities vary in their ability to get access to this clinical data. And so right now we are in the situation where most of our 11 ECDS measures are voluntary in terms of reporting. However, we have our first publicly reported ECDS measure in HEDIS now, which is a prenatal vaccination measure. Now, not all great ideas make great measures. We have situations where you might know that something is clinically important, but it might lack specific evidence. It might be an area where science is changing rapidly. And in some cases, there is a good argument to be made that risk adjustment would be important to the performance of a performance measure in this space, and that it would be appropriate to do, but it might be very hard to do or impossible to do. There are several technical problems that come around with measurement. If there are small numbers or small numbers of cases or small numbers of events, then it's very hard to get a reliable measurement that compares one entity to another. Data sources are also potentially a problem because you might have different capacities to access different kinds of data among different health plans, and therefore you wouldn't be able to have a fair comparison across them. And then there are sometimes external issues. Users, and that includes clinicians and health plans and patients potentially, should be able to understand the results and understand the link to quality. Sometimes there are health plans have actually limited capacity to control or influence certain kinds of outcomes. So those measures aren't seen really as being fair. And then finally, other differences in delivery systems in regions of the country or in populations might also make it difficult to make a fair measure. And so therefore, really impossible to make a great measure. The HEDIS measure development process goes through a set of repeatable steps, and I'm going to just say a word about each of them, but it goes in this cycle. And so if we look at selection, that means that we pick the topic area, and we almost always conduct an environmental scan, review guidelines, review available evidence, and consult stakeholders. We then prioritize these concepts because we can't do, our eyes are bigger than our stomach. We can't do all of the things that we want to do. When we do measure development, this is an iterative process that includes repeated asks of stakeholders of their opinions. So we have assessment of feasibility, we evaluate importance to make sure that there's a gap in quality, we draft specifications, so that's really the outline of the measure components, the denominator, the numerator, exclusions, and then we do testing to assess the scientific soundness of our idea. We have an important bolus of stakeholder input when we do public comment. So public comment is undertaken for every single new measure and almost all of our reevaluated measures. Our annual public comment period is held in February to March. We happen to be doing an additional public comment period right now, so in October of this fall. And the stakeholders that look at our public comment include health plans, clinicians, specialty groups, consumer groups, policymakers, and advocacy groups. We get feedback that runs the gamut from relevance and importance to feasibility and burden. We sometimes get a detailed comment about a technical specification, and many times we get global measure development comments. First year analysis. First year is important because we don't publicly report measures in their first year of existence. We review measures to make sure that they're working as we planned, that it's feasible to report the data, and that there appears to be a variation in performance. After that first year status, measures that succeed well on all of those counts can be voted forward to public reporting. And public reporting is used, stakeholders are told during the October technical update which measures will be publicly reported. And then the following summer, the results are made available on NCQA's Quality Compass and incorporated into NCQA's health plan ratings. Evaluation is important because our measures are periodically looked at for updates. As you can imagine, evidence changes, and so measures need to change as well. We review updates to guidelines or changes within the healthcare delivery system. Sometimes there are new interventions or new codes that need to be added. We review feedback that comes in through our policy clarification support system. So this is what health plans who are reporting HEDIS measures use to ask questions of us about specifications or details about what counts. They put those queries into the policy clarification support system. And that is a great source of us to get feedback. It's a constant feedback loop for us in our measure development. We also solicit feedback from our our specialty panels, our public stakeholders, federal partners, and other users of our measures. And we look at all the historic performance results from our measures. So ongoing maintenance means that even when we're not reevaluating a measure overtly, we have this low-level constant updating that goes on where codes are reviewed, drug codes, NDC codes. We have special NCQA panels that look at those codes. We update the models that are used for risk adjustment. So we use CMS's HCCs and CCs for risk adjustment. And so whenever those are updated, we have to update our models as well. And we review the feedback and comments from the field. As I mentioned, the policy clarification support system, as well as other entities such as the HEDIS users group. Now, not all measures are destined to live forever. Sometimes there's a good reason to retire measures. If the quality gap has closed and everybody's doing great, then that might be a reason to retire a measure. There might be better measures available. We may have been able to raise the bar in terms of quality, and then we can retire the lower bar measures. So when we put our measures into health plan accreditation, as I mentioned, we also use measures to compare plans to one another. And we have other programs that we use to ascertain that health care is being provided in an excellent way. We have a diabetes recognition program. We have a patient-centered medical home recognition program, patient specialty practice recognition. All of these exemplify our commitment to measurement, transparency, and accountability. And with that, I think I'd be happy to answer any questions that folks have.
Good afternoon. I'm Bob Smith. I'm going to talk with you about HEDIS and cancer screening. So the HEDIS data set it's been published annually. Its intention is to guide employers in making choices about plans by being able to compare them on the delivery of important chronic disease management services or cancer screening. And over the years, in particular, there has been a strong interest in the degree to which getting a HEDIS measure can in fact be a catalyst to increase cancer screening rates. The assumption is, of course, if you have to measure it, you're going to be paying attention to how well you do at that particular task. Right now, there are 3 measures of cancer screening in HEDIS: breast cancer screening, cervical cancer screening, and colorectal cancer screening. These measures follow the Preventive Services Task Force recommendations. And as the task force recommendations evolve, so do these HEDIS measures. And I'll give you a good example of that. Cytology screening is increasingly viewed as, in fact, has been shown to be less effective than HPV testing. At the same time, we are not entirely certain that all women in this country have access to HPV testing. So right now, there are options for cervical cancer screening that include cytology every 3 years for women ages 21 to 64, or HPV-based testing, which would include co-testing, an HPV test and a cytology test for women ages 30 to 64, but also a primary HPV test. And in other words, an HPV test alone every 5 years, which is the preferred test from the American Cancer Society, and one also prioritized by the Preventive Services Task Force. Co-testing and primary HPV testing have roughly the same sensitivity, but primary HPV testing is much more efficient because you are only doing one test and you are going to have send fewer women to colposcopy. HEDIS measures for breast cancer screening, as you would expect, follow the task force, which means it would be a mammogram every 2 years for women ages 50 to 74. But note that in this particular measurement guide that there is a 3-month grace period built in, which is a nice degree of flexibility because none of us get the tests that are recommended on time. And it gives some flexibility to plans to be able to accommodate those people who are a couple months late in the measure and include them in the measure. For colorectal cancer screening, there's also this degree of flexibility. As you can see where I have these arrows, that flexible sigmoidoscopy and colonoscopy can be included in the measure if, in fact, the test has, been taken, has been undertaken, within 4 years prior to the measurement year for flexible sigmoidoscopy and 9 years prior to the measurement year for colonoscopy. Note also that a common, still unfortunately too prevalent way of performing colorectal cancer screening is when you do a single sample stool test after a digital rectal exam in the office, is specifically called out as not qualifying for the patient having had colorectal cancer screening. This is a kind of testing we've been trying to discourage for many years because its accuracy is so low. Now, I'm going to focus mostly on colorectal cancer screening, and these are the colorectal cancer screening rates from the various plan types from 2008 to 2018. And you can see that there's 2 different kinds of commercial plans, commercial HMO and commercial PPO, and there also are 2 Medicare plans. There's Medicare HMO and Medicare PPO. The trends for these 2 types of plans are combined and shown in the graph on the right. And as you can see, in 2012, the performance of these 4 plans, which have been roughly similar then, diverged rather dramatically. And this was because that was when the CMS established the STARS program, which provided additional incentives to achieve high rates of screening, in particular financial incentives that would work to the advantage of a plan if in fact it got its rates up to the levels that measured 4 stars, for example, or 5 stars. The HEDIS measures alone did not have that impact on the commercial plans. Now, back to this issue of, well, does a HEDIS measure, if you get a HEDIS measure, is it going to contribute to increasing screening rates? And I think the example of colorectal cancer in the study that was done in Pennsylvania is a very good one. So around 1999 and 2000, there was a nationwide survey that looked at how colorectal cancer screening was covered. Only slightly half of the plans covered colonoscopy. Fewer than half had any system for monitoring delivery or outcome of screening. Fewer than 25% had patient reminder systems, and only 16% of the providers associated with these plans had reminder systems, and even fewer had tracking systems to monitor whether adults had actually undergone screening, and even fewer had tracking systems to monitor whether an adult who had a positive screening test had been followed up for that test. Now, in 2003, also largely as a result of petitioning by the member organizations in the National Colorectal Cancer Roundtable, NCQA decided to establish a HEDIS measure for colorectal cancer screening, and which they intended to launch in 2006. Developing a measure usually is a several-year process, and the plans are notified that in fact that a measure is coming, and it gives them an opportunity to begin to anticipate how they are going to achieve measurement of those screening rates. What this did was, to colleagues in Pennsylvania, create a nice opportunity for a natural experiment comparing the data from the previous national surveys to plans performance after 2006 in the state of Pennsylvania. So they surveyed all the plans that met certain inclusion criteria in Pennsylvania. They needed to cover at least 25,000 members and have at least one commercial plan in the state. And in the end, there were 13 plans representing about 8 million people that met this inclusion criteria, and all responded to the survey. And the survey also included questions about the degree to which the HEDIS measures actually had influenced their current policies towards colorectal cancer screening. So the table shows pretty simply that before 2003 compared to 2003 and after, there was a change in the guidelines, basically that the tests that plans would cover. They began measuring colorectal cancer screening rates, and they had a sizable percentage had implemented the HEDIS measures. In addition, what we saw was they covered more kinds of colorectal cancer screening tests, and in particular, they had established new or updated enrollee or provider reminder systems and tracking systems for adults who had been tested with a positive test. So the takeaway points from these investigators were that the plans did revise their screening guidelines to shape physician recommendations for screening, that many of them implemented guidelines that did not previously have them. They began measuring screening rates, and they established reminder systems and tracking systems for patients. These are all changes that would be viewed as very positive for those that were looking for additional incentives to motivate plans to become active participants in promoting recommendations for screening from the Preventive Services Task Force or the American Cancer Society, and in particular to use benefits that were included in the plans that they might otherwise not been using. So in summary, and given the limited amount of time, I was not able to show you the other data, but there are studies that have shown that HEDIS was influential in raising breast cancer screening rates and shaping how evolution in cervical cancer screening rates were taking place. The influence of HEDIS is enduring, but it's greatest during the period when the uptake of a preventive health intervention is low. As you saw, metrics tied to more direct incentives, and in particular revenue, such as the Medicare STARS program, create additional incentives that seem to push performance beyond what is, you might say, are the average levels of screening that we see in the population, that really at that point don't really allow the employer to distinguish much between one plan or another. One good bit of news is this past year, NCQA agreed to work with National Lung Cancer Roundtable member organizations to explore developing a HEDIS measure for lung cancer screening. That's going to also stimulate, I think, a lot of work to recommend best practices in identifying adults who are going to be eligible for lung cancer screening. If the task force draft recommendations are accepted, and we have every reason to believe that they will, it's going to broaden the number of adults who will be eligible for screening, which I believe will exert additional pressure on plans and health systems to identify these people and get them in for screening. And ultimately, we should see the contribution that HEDIS has shown with screening tests in the past to contribute to an acceleration of the uptake of lung cancer screening beyond what we've seen right now. Thank you very much.
All right. Thank you everyone for inviting me to join you today. My name is Hannah Green and I'm the National Director for Health Policy at the American Lung Association, and really hope that my presentation today can help us all to better understand some of the quality metrics that are important to lung health, especially those around asthma and tobacco cessation, and some of the key considerations, challenges, opportunities, impacts, other lessons learned that we can take from those metrics that can inform our conversation about quality metrics generally today, as well as our conversation about developing a metric specifically around lung cancer screening. So first, why are we talking about quality metrics? I really see quality metrics as an important tool to drive improvements in access to guidelines-based care, whether that be asthma care, tobacco cessation treatment, or other key benefits for patients with lung disease. And this can be driving improvements in coverage of services that are not uniformly covered by different payers, of services that are currently covered, but that have fairly low uptake, which is, more of the situation that we're in for lung cancer screening. So I'll talk a little bit more about that later in the presentation as well. Just to level set, I want to talk and briefly introduce you to two of the measures that I'll be referring to as examples throughout the presentation today. The first is the asthma medication ratio. Now, this is a HEDIS measure developed by NCQA, who I know we're also hearing from in today's panel, which assesses adults and children ages 5 to 64 who are identified as having asthma and have a ratio of controller medications to total asthma medications of 0.5 or greater during the measurement year. And that basically means that when you look at the medications that a patient is taking for their asthma, are the everyday maintenance medications that taking regularly is often helpful with good asthma control. Are those medications the majority of the medications that a patient is taking, or are patients relying often on emergency relief medications, suggesting again that maybe their asthma is not being particularly well controlled? The second metric I want to introduce is around tobacco cessation. This is medical assistance with smoking and tobacco use cessation metric. Again, this is developed by NCQA. Unlike the previous metric, it relies on survey data, and we'll talk a little bit more about that later as well. But the three kind of key questions that we're looking at here are, for adults over 18, have you received cessation advice during the previous year? Have you discussed or been recommended cessation medications? And have you discussed or been provided cessation methods or strategies, again, during the measurement year? So when we're thinking about quality metrics, I want to start by thinking about who are the payers that we're trying to influence. Who are the payers that are covering the patients that we want to see improvements in care for? So for a metric for lung cancer screening, we know we would want to have a metric that influence change in the commercial market, in Medicare, and in Medicaid, based on the patient population that's eligible for screening. I will also just stress that given the USPSTF recommendation that was released this summer, if finalized, would decrease the age of eligibility for screening to 50 years of age. And so a lot of the newly eligible for screening would be covered by the commercial market and by Medicaid. And so I think it's really important that we think about metrics that could, again, really focus on and be utilized by those payers in particular. Luckily, the NCQA HEDIS metrics that we've been speaking about are dominantly used by all three of those payers. That's certainly a great starting point for us to be having this discussion. I also want to talk about Medicaid coverage in particular, which is a program that is particularly important for the American Lung Association, especially because patients with lung disease are disproportionately covered by that program. And a big part of that is because Medicaid enrollees smoke at a rate over twice as high as those with private health insurance. And so again, given the reliance on tobacco use history and the eligibility for lung cancer screening, that's going to be a sign that Medicaid it will have a number of enrollees who will be eligible for screening, and we want to make sure are getting screened. So if you're not familiar with quality metrics in the Medicaid space, there are two key sets of metrics that we really track: the child core set metrics and the adult core set metrics. These are currently voluntary metrics, although the child's core set and the behavioral health metrics in the adult core set will start being mandatory in 2024. They currently include both the asthma and tobacco measures that I spoke about on the previous slides in the adult core set, and a version of the AMR, the asthma metric, is also in the child core set as well. So looking at the adult core set, which is probably more important for the conversation we're having today around lung cancer screening, while the measures are voluntary, there are currently 33 measures in that set that are reported by Medicaid programs. 40 states report more than half of those measures, and the median number of measures reported, this is for calendar year 2018, was 22.5. So even though they're voluntary, there is fairly good reporting of these measures, and I think that they're thinking about a measure that could be included in the adult core set is really important as we think about a measure that could influence change and improve care for this particularly important population. So turning to some of the challenges and opportunities that we've seen with our experience in asthma and tobacco cessation metrics, I want to start by talking about the challenges in measuring exactly what you want to measure. And certainly starting with asthma, medication usage is not a perfect measure of asthma control by any means. And I have been part of multiple conversations over the past couple of years about how can we get a metric that is more comprehensive, that incorporates more data, that is a better measure of asthma control for patients. And often those conversations, end up getting sort of bogged down in questions about, well, if you want something else, where are we going to get that data? How practical is that? Is it, uniformly collected by providers? Can we get it from claims data? And so I think a lot of those challenges are challenges that we also may face in talking about the development of other new metrics. But I also want to say that even a metric that has its limitations can still be impactful, and I'll talk about that more in a minute. The other big challenge that we see is around tobacco use information, which of course will be directly relevant to the conversation about a lung cancer screening metric. First of all, when I talked earlier about the metric that we have for cessation relies on survey data, which introduces some potential biases. We know that smoking history is something that is often underreported by patients. There have also been issues with sample size in certain cases, and so we know there are some limits to using survey data to collect tobacco use information. On the flip side, when we talk about, again, developing a metric for lung cancer screening that would rely on, the tobacco use history to determine eligibility criteria, there are limits in other places we could get tobacco use information. Electronic health records, that information is often, recorded in different places and different systems, whether it be in specific fields or in the notes section. There can be challenges with recording change over time. So certainly there are questions about how are we measuring tobacco use that I think we'll certainly have to grapple with as part of this discussion. But, turning to more of the positive side, I certainly want to talk about impact as well. And as I mentioned earlier, really, I see quality metrics as being an important tool to drive improvements in both coverage and utilization of services. And we've already seen evidence of that starting to happen with the asthma metric that I spoke about earlier, even though, as I've acknowledged, it has its limitations. And so just to give an example from the Medicaid space, some of the services that we are interested in and have been tracking changes in coverage of over time at the Lung Association is asthma home visiting services. So these include both environmental assessments in the home, maybe self-management education in the home that can help patients better control their asthma, address triggers in the home, and learn how to better manage it. So we have seen over these are services that are not often covered by state Medicaid programs. But we have seen over the past few years, state asthma programs and other stakeholders increasingly partnering with their Medicaid programs and saying, how can we share data? How can we look at a, say, pilot program that we've been running and say, this is the population. Let's look at their data, their claims information before and after this intervention. Is there a change in the AMR? And if there is, that can really be helpful in building a business case, building the evidence base for Medicaid managed care plans, Medicaid fee-for-service programs, other payers to show this intervention works. We need to improve access to it, increase coverage of it, increase investments in it. And so I really think that that's a great example of the kind of change that we can hope to see by finding a quality metric for lung cancer screening. And I will say, again, focusing on the Medicaid space, the Lung Association for the past couple of years has been tracking Medicaid coverage of lung cancer screening in fee-for-service programs. And we have found that there are still 9 states that don't cover screening for their traditional Medicaid population, a few states where we still don't have data available. And so certainly a quality metric could be an important incentive to improve coverage in the states where we still don't see it. But also we know that across the board in Medicaid and other payers, utilization rates are still alarmingly low. The American Lung Association State of Lung Cancer Report for 2019 found that nationally 4.2% of those eligible for screening had been screened. We'll release updated data as part of our State of Lung Cancer Report in November, but still there is certainly quite a lot of work to do to improve utilization rates of lung cancer screening. And so really hope that across all payers, a metric could be an important tool to incentivize investments in patient education, provider education, quality improvement programs, other interventions that could really help increase awareness and access to screening, even when it already is covered by payers. So I think with that, I will leave it there and thank you for your time, and I'm happy to answer any questions at the end of the panel.
Well, I want to thank our speakers for terrific presentations, which was so full of content and solid information. I almost don't know where to begin with questions. But I do have one. I've been coming to the quantitative imaging workshop for a few years, and of course, lung cancer screening is core to most of the discussions, maybe all of the discussions. And there's organizations that are doing screening now, integrated delivery systems, and they speaking with the people the pioneers who are running those programs, they say, well, what's the problem with a measure? My organization has an electronic medical record, and we go through it and we identify the people that we think are eligible, and we start the phone calls and get them, see if we can talk them into getting screened and reach out to their primary care and so forth. And that's through a provider-based electronic medical record. But so I'm going to direct a question at Dr. Barton, and on the barriers to that kind of approach, because it's the folks that are at this, some of the people at this conference, the provider-based organizations can probably do it with the patients that they have in their electronic medical record. Why isn't that good enough? Dr. Barton?
Yes, thank you for that question. I think that the difference between something that a few people can do or some places can do and something that is achievable by all health plans, because really the benefit of benchmarking, which is what so many people use NCQA's information products to do, to benchmark their own performance. And it's really, there's no benchmarking unless you have a national look at how something's being done. And so we're, at this time, we're really pushing as hard as we can. We've got a digital quality summit that we run every summer. We've got a digital community that's, anybody who's interested, come please join our digital community. Come to NCQA's website and join us. But we are not in control of the access to electronic healthcare information of health plans across the country. And every health plan has its own particular speed bumps in front of it. Some regional health plans are already in control of all the EHR information for their members. And that's great for them, but they can't, there's no way to compare them to, United and Cigna and Aetna, these nationwide plans that have, thousands of such relationships in terms of with practices. And so, NCQA is working on ways that there might be intermediaries, like maybe a health information exchange in a state could be an intermediary for health plans to get data from practices. And that's something that we're interested in and we're actually working on. And we've got a pilot that we've done with New York State, but the problem is we need the world to move a little faster than it's moving before we can institute a measure like that and expect everybody to be able to report it.
Well, thank you very much. I suspect some of the panelists in the next hour are going to have some strong opinions about the practicality in their situation. So I hope everyone can stay tuned for the fireworks in the next hour. But I wanted to ask thank you very much. Hannah, I loved how you said, well, the measures may not be perfect, but they're useful. And I wonder if you could elaborate on that just a little bit. That where is the balance of between something that's useful and something that's helpful and something that's perfect?
Yeah, I think one of the key things, and I'll probably go back to the asthma example there as well, is thinking about the end result, the change that you hope these measures are driving to. If you're looking for, in the asthma world, you're hoping to incentivize plans, providers, patients to all do a better job in terms of asthma control. If a measure that you're looking at is not a perfect measure of asthma control, but is still incentivizing all of those different players to make investments in improving asthma control, I still think there can be a huge value in that. But at the same time, if something is not perfect, you don't want it to be incentivizing investments that might make an improvement on what you are measuring, but not make the improvement in sort of the big picture. So if a measure isn't designed well and doesn't, it could incentivize, improvements in a measure, but not improvements in sort of overall asthma control, overall screening for the high risk population, whatever the end goal is. So I definitely think it is a balance.
So is it in your measures, which are measuring tens of thousands, hundreds of thousands of people, is it okay if some of the individual contributors are not perfect?
Well, I think it's really more about, is the measure design, is the measure capturing what you want it to measure? And it may not be a perfect measure of asthma control or of, whatever your measure is. I think it's important that the data that's populating that is as accurate as possible. But really, at the end of the day, when we're talking about, is it perfect? Is it really matching that end goal as best as it can be?
Thank you very much for that. I see Bob Smith is, I think you dropped off. We had some internet problems, but I'm glad you're back. And I have a question. Bob, you showed a fascinating chart that showed that coincident with startup of the STAR metrics, that colorectal cancer screening increased dramatically for the Medicare Advantage plans, but it didn't seem to move so much for the commercial plans. I wonder if you could elaborate on why the commercial plans didn't show that the same sort of improvement.
I think it's a really important question. Can you hear me, by the way, Bruce?
Yes, we can hear you.
Okay. I apologize. This is the internet and the power have been going on and off and on and off. So they're clearly doing something in the neighborhood. I don't have a good explanation for it. I think Mary might, but it just strikes me that the STARS program layered on a different level of incentive that really must have stimulated a great deal of motivation, among the members to get those rates up. I did want to, mention one other thing in the context of what Mary described earlier about, what the challenges we're going to face with a HEDIS measure for lung cancer screening. And to your point earlier, we really have seen, a number of centers really embrace this opportunity to reach out and identify patients who would be eligible for lung cancer screening. But I think that's not most places. And the electronic health records, clearly it never saw much purpose in estimating PAC years, or even making sure for some electronic health records that PAC years didn't get recalculated on a rolling basis based on current patterns of smoking. Kaiser actually surveyed a segment of plan members just to try to measure against what the records showed, and roughly doubled the number of patients that would have been, qualified for lung cancer screening. So I think a challenge we really do face right now is that we have to find a way to get all of these records up to date, one way or another. And we have heard about some approaches using artificial intelligence that really are a major help in identifying those patients who are very likely to qualify just by making use of information in the record. I think we're going to have to really promote a range of strategies and try to find some collective strategy to make sure that going forward, because now it is relevant, that qualifying information on risk, which right now is tied to smoking history, has to be in every patient's record.
Well, thank you very much, Bob. And that's a perfect segue into our next panel. I want to thank our three speakers again, for just a wonderful, enlightening and exciting introduction for the folks who are listening in from the quantitative imaging workshop. This is really, really important information for the future of healthcare and population health and lung cancer screening. And I want to thank you all again, and hopefully you can continue to listen in, because we might want to ask you some more questions on the follow-up. But I'm going to introduce our next panel and share, if I can share a few slides and start off. And Bob knows me well enough that, of course, I'm going to disagree with him in my introduction, and we'll engage the speakers around some very pointed topics for lung cancer screening. The overall topic is how would payers and providers react to a hypothetical metric for lung cancer screening? And I'm going to create a few straw dogs to put out there, because NCQA hasn't done its work, hasn't it yet? Hopefully that'll start very soon, but So these are all hypothetical and subject to a lot of work the straw dogs are going to present. But let me introduce our four speakers: Congresswoman Allison Schwartz, former U.S. representative, and as president and CEO of the Better Medicare Alliance. It represents the Medicare Advantage industry. I've got to say that over the years, the information they've put out has been the best and objective and clear-cut information about the role of Medicare Advantage. And for just to get it out there, Medicare Advantage covers not quite half, but getting up there, over 40% of the people in Medicare with both Parts A and B, and that's expected to continue to grow in the future years. It's really important for covering seniors. Lisa LaCarupa is medical director, clinical re-engineering at Horizon Blue Cross Blue Shield, but she was telling me what that really means is she's creating and implementing the value-based programs for Horizon Blue Cross Blue Shield, which is the dominant health insurer in New Jersey. So she's very intimately familiar with the quality metrics and how to get providers to move their quality metrics, because Horizon has a big Medicare Advantage plans, and if the providers don't help with the star metrics, that's not good for Horizon. Elisha Washington is Vice President of Clinical Quality at Health First, which is the biggest health insurer local in New York City in the boroughs. And she has seen it all when it comes to quality metrics, from doing the audits to running a big health plan, and again, getting their providers to make sure their health metrics get where they need to be. Health First, by the way, is owned by the big healthcare systems in New York City. So it's an interesting arrangement that they have with their owners, who are also their providers. And finally, Suresh Mukherjee is a radiologist who has a background in employer coalitions, which are purchasing groups and collaborative groups of employers for health insurance. He's also been active in Certificate of Need, ran the Certificate of Need board in the state of Michigan, and very interested in socioeconomic determinants of health. So I am just thrilled that we have the four speakers. I couldn't have hoped for a better panel. I'm going to start with the straw dogs, and these are hypothetical. And I'm going to ask the panelists, okay, so suppose one or all of these or something like these is implemented. I'm going to ask you guys, well, what are the health plans going to do? How are the providers going to respond? The first straw dog is the traditional measure. It's the ratio of screen members to the members who are eligible for screening. And as we've heard, it's really hard to know who the individuals are that are eligible for screening, because the data is just not there. It's not even there in electronic medical records. And if it were there in electronic medical records, nobody wants to spend the money to get it. So my view is that, just personally, I think it's hopeless. I think the traditional measure won't ever work, at least not in the next 20 years. So we should stop wasting the effort to try to make it work. So anyway, that's my view. But there's a couple of other approaches. They're all straw dogs, and a stage shift is one of the approaches. What happens with all cancer screening is, the reason it works is that people get shifted to earlier stage than late stage. And that's something you can kind of find out through the claims data. So you look at all the incident lung cancers, and ICD-10s don't really help because ICD-10s don't have stage of cancer, but you can assign a pseudo stage by looking at treatment, looking at patients who go right to hospice, late stage, or patients who get surgery and chemotherapy might be late stage or middle stage, or patients who just get treated with surgery, probably early stage, and those that survive. So you could get a pseudo stage looking at a population, and that could be done in claims quickly and inexpensively. And the third straw dog is yield, uh, which is to look at the total number of incident lung cancers in a year. That's the denominator. And look at the ones that were diagnosed after screening. And if you get a higher portion of your lung cancers that are found followed screening, that's a good thing. It means screening is being done, and it probably means earlier earlier stages and better patient outcomes. And I love the example Hannah Green gave of the HEDIS metric of rescue meds to total meds, or I guess the opposite, the chronic meds to total meds for asthma. That's not quite an outcome. That's a process, but it's meaningful and it gets in the right direction. So those are the three straw dogs. So I'm going to start by asking Congresswoman Schwartz about the Medicare Advantage plans and how important do they view star metrics and quality metrics, and what would they do if there was a lung cancer screening metric, if one of these three straw dogs or something else was actually being used? Congressman Schwartz?
Yeah, thank you. And really very much appreciate being a part of this conversation. And I listened in, of course, for the first session, and it was really helpful to get a context. So I hope what I want to contribute first is certainly that playing off some of what you asked, and one of something certainly we heard in the first session is star ratings really work. You sort of heard that in all the presentations, and even your question, Bob, was really an interesting one, is why does it work so well in MA? And the answer there, I think, is the way it's structured. And the fact is that these are measures that can be, particularly ones focused on HEDIS now, some issues maybe with the consumer experience measures need to be modernized. But they are measurable, they're meaningful, and at least that's the goal, and that they really are actionable. And absolutely the plans take this seriously. And one of the reasons they do is the way STARS has been set up is to provide real incentives. They're not penalties, they're incentives. And the incentives are really have to be used. The dollars and the incentives are quality bonus payments that are used and have to be for additional benefits to beneficiaries. And that's where some of the competitive edge comes in terms of the plans competing with each other. And it is also very attractive to beneficiaries. So beneficiaries have to say, you're right, it's growing, it's over 40%. People think it's moved to 50% at some point, not in the too distant future. And in some areas, it's well over 50 or over 60% in some counties in the country. So we're seeing a real appeal to consumers. It's about their affordability. It is about the extra benefits, about the care coordination, the integrated care. Now, you could also say one of the reasons it works in MA is because it isn't an integrated care system, and it does take plans making the investment in identifying knowing these measures and making the investments in what does it take for us to make this work. You just heard it in that presentation Bob gave about it's not just having the benefit, it's actually, I would even add, identifying those, and you suggest that in the last question you asked, was You need to identify the people who need to use this benefit, and then you go after them. And that's something that can happen in a prospective capitated system that simply does not happen in fee-for-service in the same way. So Medicare Advantage is a huge example of how this works and works well, but it probably doesn't come just by itself. It comes from the fact that the plans are taking financial risk for the health of the patient over time. And that creates an incentive for them to do something like screening to identify people early, use the identification of those patients at risk and act on it by notifying them, by trying to get them in for care, and trying to have their providers talk to each other. All of those things come together to make this work. So what's extraordinary is about the success of STARS. I'll just use one somewhat astounding statistic is in 2011, there were 24% of beneficiaries in MA plans that were in 4- and 5-star plans. Those are the top rated. There are now 77% of beneficiaries are in plans that are high quality. And again, for those who, it was a great explanation about how this works, but to understand that these measures are not static. They're on a curve. The CMS controls that curve. They limit the number of plans that can get to be 5-star plans. Obviously, they can modify the curve. They don't want to. Because it costs more. The bonus payments are higher in a 5-star plan. So there are a lot of plans in this force get to 4, get to 4.5, 0.7, 0.6, and it also moves constantly. The stars themselves move, and the plans are not told ahead of time of what the exact rating of those each quality measures will be. And in fact, they do give you notice about certain things. For example, they've given notice that the consumer measures that we think ought to be modernized are going to be double weighted in 2 years. So there'll be much more concentration on those consumer measures. There's some issues there because we think that there's some changes that could do to improve those measures. But in HEDIS, they go after these measures and they've done really well. The increase in the number of screenings for people with chronic conditions, really has changed. We have some statistics on that. If you want to go to some of our research papers, we have another one coming out in just a few weeks on frail elderly and those with complex chronic conditions. And MA does much better than traditional fee-for-service Medicare in achieving these goals that are set by the government and are monitored. And I will say they spend a lot of time and money. I think that Mary pointed this out in making sure they not only work with providers to identify and to identify those people who need it, and then go and get women. There are higher percentages of women getting mammograms, for example. And we also have on almost every screening metrics, MA does better at getting patients in. So for those screenings, which then of course lead to treatment, diagnosis, of what's going on. But there's a lot of effort in terms of the prevention. Again, so I'll just mention one because it was brought up in the previous conversation too, is that one of the areas that plans use supplemental benefits for example, is tobacco cessation. So it's covered. It's in, I think actually, Bruce, you did some of this research for us, over 1,000 plans out of the over 4,000 plans. So maybe not everywhere, but that's still, you're talking about millions of beneficiaries having access to a benefit they would not get otherwise in traditional Medicare. It also means that they're probably identifying these patients and working with them in other ways as well. So, I could go on to talk about some of the other ways that STARS works, but I will say you heard the process for getting new measures in. Going forward, you should work on that. I'm not an expert to say what that measure should be and exactly how it should be applied. That takes a good bit of work to make it work. But I am well aware of the fact that there are concerns about how these measurements are conducted. There always are. You retire some of them, they bring them back. You want it to become the norm. Does it stay the norm forever? Are the measures the right ones in terms of our national goals for health? Which will be the most effective? If you have too many, is that makes it harder for plans to provide the attention each of these measures need, harder for providers to do that. There is also some interest in terms of limiting the number of measures and being really targeted about them. So that might mean there's more competition in terms of whether this measure is the one to do it, and to include, and which ones would you drop. There's also some interest, actually, in a part of more recently of MedPAC wanting to undo the way STARS gets its incentives. I think it's not been, it's only been a conversation so far, but I think there should be a lot of worry about the possibility of taking away these incentives, reducing the quality bonuses, making it a more of the same kind of pay for performance that maybe hospitals have, where it's a withhold, there are penalties, you don't get the money if you don't do it right, you don't know if you're going to make it, and yet there can be some incentives at the end of the day, but to narrow those and to bring back, so to take what I think is an extraordinary success story and suggest that it needs tweaking or undoing, even worse, I think is very threatening to this whole movement to not only just in Medicare Advantage, but in really being able to provide quality measurements that really matter to the health of beneficiaries, can be understood by beneficiaries. In Medicare Advantage, the star ratings are posted with each plan on the plan finder. Now, a lot of beneficiaries don't use an online tool, they use the handbook. The timing isn't quite right to add those. Let's figure that out so we can actually give you some idea of what the star ratings are. And to continue this incredible success of moving our healthcare system to one that really quite monitors quality and provides the incentives in the system that doesn't reward, just do more of the same, rather than how can we actually improve the health of beneficiaries and actually the American people. So sort of grand picture there, rather than maybe some of the granular questions you might have for the others, but I thought that might be a helpful start.
Well, thank you very much, Congresswoman Schwartz. And I wanted to pick up one thing you had mentioned and ask Elisha and Lisa to comment on it. You described briefly how health plans act to get their physicians and their members to do the things that'll result in higher quality metrics. And I wonder if, you know, I'll start with Elisha. If you could describe
Sure.
how do you guys do that, and how might you do it for the lung cancer screening
Sure.
metric?
Yeah, I mean, I think that's a very good question, Bruce, and I think that it's probably something that's a big mystery to physicians, especially those who are not really close to this quality improvement work. But for those of my colleagues on the phone who have any payer experience or have worked at an insurance plan, it's very much core to what we do in quality programs. I do want to just, underscore what, Congresswoman said, as well as what Hannah said, is that STARS ratings really work, for sure. We have actually also in New York State, there's a very strong Medicaid program that also is a big proponent of ratings and, transparency over health plan ratings and rankings as well, so there's a tremendous amount of interest in our market around these measures and how they do. So the burden then falls to the health plan is to really go ahead and, I would say, educate our providers on the requirements around these measures. So at Health First, what that means is that we take a pretty active role in going out and educating our providers. You mentioned before, Bruce, our sponsor hospitals, we have 15 sponsor hospitals. Those are huge health systems, Montefiore, Northwell, Mount Sinai, that we actually engage them in face-to-face meetings in a pre-COVID world, obviously, but where we're going out and talking to them about clinical quality guidelines, measure specifications, really the requirements around measures, which includes, who are the eligible populations that need to get these particular screenings, or if it's a chronic care management measure, what they might need or what's recommended from a chronic care management perspective. And spend some time really enforcing, not enforcing so much as really, talking about how the health plan really supports these metrics, And how we do so is in a few ways. We'll go ahead and make sure that they're endorsed as part of our quality committees, right? So we'll go ahead and make sure that on an annual basis, we'll go ahead and include anything that's an important measure in our quality committees as far as our clinical practice guidelines that, Health First will say, for example, that we are in support of. And then we embed, and I'm sure Lisa can speak to this a lot as well, we'll embed a lot of these actual measures in our incentive programs that we pass down to our providers. So the star ratings are important to us, obviously as a health plan, but what we do is we actually really, speak and take down to the providers incentive programs of their own, pay for performance programs, or other value-based payment arrangements where we include quality metrics in the actual arrangements that we have with these providers. So in my experience, it takes kind of a combination of things, like really making sure that we're educating on the measures, as well as then actually offering some, financial incentives attached to doing well on these metrics. In my experience at Health First, adding of incentives has obviously caught the attention of providers. Anything that we can bring forth as there's an opportunity to earn more than just your normal cap arrangements or your fee-for-service payments that you're receiving. And the other thing that really has been helpful, here in New York City, as you'd imagine, we have quite a few MA plans. So market pressure by multiple payers, also gets the attention of providers. So if Health First is including something in one of our programs and Emblem is as well, and Fidelis is as well, it certainly helps to gather the attention and helps really to move rates. So from provider perspective, I think, getting providers on board has not been it's not something that's really, I think, difficult, but I do think, what was mentioned in terms of like the number of measures and confusion over what needs to be, what's the most important thing to measure is sometimes, I think, the difficulty. But I think the methods are similar regardless of the measures that you actually, will put forth.
Well, I want to hear from Lisa because, with Elisha's owners are the providers. So you've got one kind of relationship with them, but Blue Cross is certainly not owned by the hospitals and physicians in New Jersey. How describe your situation of trying to get get this all of this working?
Yeah, we do a lot of the same things, even though we're not owned by the hospitals and the physicians. But it really starts with trying to take that metric and embed it in the program. And how do we make that decision to embed the metric in the program? The numbers are huge, so there's a limited number of metrics you can put in a reward program, whether it's Medicare, Medicaid, or STARS. So one of the things we look for is, are these being used in multiple different programs? If it's being in Medicare, Medicaid, and in STARS, and in commercial, we say, oh, wow, that's in a lot of different places. Hey, is it also an ECQM for CMS? Is it in CPC Plus or Primary Care First or MSSP? Is it in a lot of programs? So the physicians will pay attention to it because it's in a lot of programs. Then it's more likely that we'll put it in our program. There is a limited number of metrics, so we have to make the decision, what do we drop out of our program? We can't just keep adding metrics to the program every time a new metric comes on. So what we usually do in the first year of a new metric is we make it a demonstration metric. We're not going to grade you on this metric in the program, but we're going to put it in so you can see how you're performing. Our physicians tend to be competitive, so they want to know how they are performing. They want to do well. They're aiming for 100%. I always have to remind them, you're never going to get 100% on a screening measure. There's always reasons people can't be screened, but you're aiming for 100%. So we can show you how you're doing. That's also a good year to work out the intricacies of the measure. One of the things that we do, we go out and teach, just like Health First, we go out and we teach about the measure, what it means to do the measure, how the specifications are, who qualifies. we also have to teach them how to implement the processes. So for most of our measures, and actually this is one of my biggest concerns, and a couple of people said this earlier, how do we determine who needs this service? Because we usually provide reports to physicians, identifying for them the patients who need the service, who have had it and who haven't it. That information comes from the health plan. It often supplements what they have in their EHR, but we provide that information to them. How would we do that with this measure? How are we going to identify that? How are they going to get the information back to us? We heard a lot from NCQA, administrative measures, claims only, but we know that claims are not the whole story. Is there a way we're connected to the EHRs? How does that work? What EHR do you have? There's all that. So we work that out in the first year. And then in the second year, we can bring it. We have a committee of physicians that has to agree to the measures that we're going to put in. Will the physicians looking at how that measure work? We've had years where they've said, that measure is a nightmare. Please take it out of your program. We're having lots of issues with your data, with our data, with communicating. And there's other times they go, yeah, this is working really well. So that second year, it would be more likely to be in the program. And then we could also be doing more about how do you look at your population now that you know what the metric is. Let's look at your scores. Year two, there's comparative scores out there. Year one, we usually can't say, hey, this is 50th percentile in the nation, or this is 75th. Year two, we have that so we can give them a goal to work towards. And then the other thing that usually happens is once we start measuring the physicians, they start asking us, well, what are you doing to incentivize the patients to get this done? So Horizon also has to create a program that is a direct Horizon outreach to the patients to remind them to talk to their physicians, or potentially with some of those supplemental benefits, what kind of reward are we giving you for getting your screening activities? And again, in order to do those types of programs, we have to be able to identify the patients, get the data so we can do the outreach to the right patients. You certainly don't want to send a reminder for a CT scan to a non-smoker or to somebody who smoked a pack when they were 15 and gave it up because they didn't like it. So you have to be able to really identify those nuances in the data, send them and do that program and properly incentivize it. And then we go to our physicians and we say, hey, one of the things you can tell your Medicare Advantage patient who has Horizon Medicare Advantage or this commercial program or this Medicaid program, hey, this is the reward that you'll get for doing it. So it's not just the reward of being healthy, which people certainly want, or being diagnosed early. It's also, hey, and here's your gift card to the pharmacy, whatever it is. So that's how we usually approach it.
Bruce, I think you're on mute.
Well, thank you very much. One of the things that struck me listening to all of you is that it'd be really great to get a HEDIS metric for lung cancer screening, but once that happens, then the advocates have to actually compete with the other HEDIS metrics in a way, especially if the number of metrics is going to be shrinking. And of course, I agree that some of the the member satisfaction interview ones probably should go away, but still there's a lot of them. I did want to ask Suresh, as the practicing clinician and out there in radiology land, how does he react to these efforts by health plans, or what would you suggest to make this happen better? And again,
no, thanks for having me. It's great to be here. I guess my journey is I sort of divide, like many of you here, in the 6 P's of healthcare. So it's always the patients, the providers, the payers, the purchasers, the policy, and the politics. And with my past journey, my continuing journey, I've been part of all of those P's. And one thing that I've seen since Bruce asked me to do this is I've sort of dialogued through my various connections, and there's overwhelming support of lung cancer screening being supported at various levels. And I was talking with one of the medical directors from one of the plans I know, And I talked to him and I said, you know, what would it be like if this became a HEDIS criteria? And he said, well, this would be great. We would certainly support it and we would figure out a way to incentivize providers. And I said, what if it became a STAR criteria? And then he said, we'd be all over it, because basically they have about 350 million reasons to be all over something like that. So it depends on how high it goes. So if the biggest tailwind would come from, obviously became a STARS criteria. I think that was elucidated very nicely. Regarding getting the providers to be engaged in this, I think it's important to understand that lung cancer screening, and we've equated this to breast cancer screening and to colorectal screening. But one thing about lung cancer screening, it's not a test, it's a program. And when you talk about a program, it's not one stakeholder. It's not a woman coming to our department and having a mammogram and then recording it with a numerator and denominator. It is an individual that is referred to into a program either by a PCP or whoever. And the program typically consists of a primary care provider, a radiologist, a pulmonologist, a medical oncologist, and a surgeon. And the programs that have been developed, because I was part of part of a large institution that successfully developed a program, and then I was part of an institution that was unsuccessful creating a program. And part of the successfulness is that many of the larger institutions, many of you all come from the big states and large institutions, have the infrastructure to support a program. The majority of the care is not performed at the major large academic institutions or the billion-dollar institutions. A lot of it is in smaller community-based programs, and the referrals come from primary care physicians out in the community. So part of the challenge is that in order for anyone to get reimbursed for the time they're spending in the current state, they have to participate in the registry, the CMS registry. And that registry from a grassroots level is very cumbersome to participate. So not only do you have to enroll the patient, you have to send them for the CT scans. Once the CT is done, you have to have someone filling out all the long-term data. And this requires a navigator. And so if you're looking, part of it is who takes ownership of that navigator. And in most practices, that's either done by a large healthcare system who have lots of resources that can easily afford a navigator. But when you come to smaller practices and you have a PCP that has other unfunded mandates that they've suddenly come across, like implementing electronic health record, anytime now that they order any type of advanced imaging service, they have to have pre-authorization. And that's an unfunded cost that they have to assume in order to get diagnostic testing. And now you say they want to do the right thing, but then all of a sudden, if they're going to refer someone for a lung cancer screening test and they want to be participatory, then they have to fund a navigator in order to pull all this data in. So part of that challenge is going to be, how do you fund this? Now, large institutions, again, are quite enthusiastic about participating in lung cancer screening because they retain all the downstream revenues if they do find a lung cancer. In fact, one of my friends who's at a smaller institution said, you know, if we find 6 lung cancers in our screening, all of a sudden we can pay for our infrastructure. That's great. But if you're an individual practitioner out in the community, and then you refer someone into a program and you don't see that patient anymore, and you set up that practice, it's hard to do. So I would, when I was talking with one of my colleagues, again, at one of the big health systems, one of the big payer systems, you know, their strategy was, you know, we will incentivize the PCP directly because they feel that they are the gatekeeper. And so when they do various quality metrics for, you know, fill in the blank, whatever HEDIS criteria you want, those payments are going to that primary care physician. So it's a bit of an anathema for me as a radiologist say that's a good thing to do. Don't give it to the radiologist, give it to the primary care physician. But I think in actuality, if we want this to succeed around the country, not just at large cities, at large institutions, but around the country, we're going to have to support the infrastructure for primary care physicians to be actively engaged in this, to be able to navigate patients to the right areas and be able to successfully complete and input the data that's necessary for longitudinal database ensure that we're getting the same outcomes.
Thank you very much. This is a very different perspective from the, from the field and the provider side. And I'm wondering, I'd ask Laisha and Lisa to comment on that. And in particular, I think there's the difference with lung cancer screening, that maybe the health plans have a bigger role of incentivizing individuals. And let me frame that by pointing out that, lung cancer screening has been B-rated by U.S. Preventive Services Task Force for several years now, and the uptake is, depending on who you listen to, is either terrible or awful, and where the highest estimate might be about 6%, and other estimates are about 2% of people who should be getting screened. So, is there a different role for health plans to move patients, to get patients to self-identify, to have the patients speak to their doctor? Lisa, Laisha, do either of you want to comment on that?
Sure. Let me jump in. I'm sure Lisa has some comments as well. I do think that we as a health plan take very much our engagement of members to do the right thing from the perspective of prevention. And we've actually taken an active role independent of whether or not there's incentives attached to, quality metrics. So from a quality improvement perspective, I do think if we were, and I'm going to kind of slow and caveat, underline, if we were able to appropriately identify a population of members who we think were at risk for, lung cancer. And I think that that's where we need some greater specificity, and maybe the clinical guidelines are clear on that. If we were able to really identify those members who were most likely to be in need of lung cancer screenings, we certainly would promote that as a health plan. I mean, we as a health plan invest a tremendous amount, in both our incentive programs externally with providers, as well as our member incentive program, similar to what Lisa said, as well as our internal quality improvement programs, really just in terms of being able to move metrics or work to do the right thing. And I think that as a health plan, especially as a payer, I'm thinking as our role in sort of New York City, and as given that we have a very large Medicaid population as well, I do think that we would have a role in helping to push forward doing the right thing. I think what Suresh had mentioned, though, is interesting, because primary care is actually the sort of vehicle by which most of our incentive programs are tied right now. It is attached to ambulatory care practices, primary care. So whether or not we were able to be successful in the provider space largely would depend on us being able to push something forward that primary care could really effectuate a change on. So in the past, for example, we've had challenges around going back to primary care physicians around behavioral health type measures, where they felt that they had limited impact to really change behavioral health metrics, because they don't always necessarily similar, right? The members don't always necessarily identify their behavioral health conditions or substance abuse conditions to their primary care physicians. So in a similar manner, this might become something that would be a rate limiting factor for us if patients and our members are not necessarily being forthcoming about their tobacco use or tobacco use over time. It might really impede both our ability as a health plan to really move forward on an intervention that's appropriate, as well as really working with providers on what they might do to then get them into the right screening. So I think there are some legitimate concerns that Suresh has brought up, for me.
Yeah, I would just jump on. I think you've made some wonderful points that are really important to us. I will say there's work we've done both at the provider level and at the member level that don't have anything to do with our actual HEDIS measures. So for example, we have actually already done some education for our providers on lung cancer screening in the form of optional webinars. We've also do have messaging for members. That's not my area that I control, but I know we do have messaging. If you called to Rise and got put on hold, you would hear general messaging about the different types of wellness services that you might perhaps need. And I think that general messaging is something that a health plan can do very easily. I think, just to echo what Laisha said, identifying the members. You turn members off if you incorrectly identify something they don't need. And frankly, you turn your doctors off. I have been in the position as a physician where patients have come to me and said, my health plan said I need this test, or I need this service, or I need this medication. I'm like, no, you don't. Your health plan has some incorrect information. It does not go well. So we really have to be able to identify folks. So one of the things we need, just a clinical recommendation, we actually did a project with this, trying to identify some of the things that were clinical recommendations, either to do or not to do, and try and use our claims data, because that's what we have is claims data. We get some EHR data, but it's not across our network and it's limited. How do we use our claims data to identify the patients who either need the service or who had a service they don't need, and we were going to give the feedback to the physicians, not even directly to the members. It's a nightmare to do. One of the things having a defined national standard is they tell you this is who counts and this is who identifies who counts. It's not Horizon made it up, because physicians hate that. They want all the plans to do everything exactly the same. You need a defined set of how you identify those particular members or those particular patients, and there needs to be a standard, and that's how you identify them. And right now with lung cancer screening, we have struggled with identifying who meets the smoking criteria for lung cancer screening. And until you can do that, we can't really do that individualized outreach to our members, because we're not going to correctly identify them. And I think I tell my team all the time, because we are working with the providers, whether it's the physicians or the hospital systems, one of the fallacies is that, health plans have all the data. We don't. We have good data. We don't have all the data. And the richness of the clinical data that we still are not getting is really a barrier to us being able to do more. Not that we don't want to. I'm a doctor. Please catch lung cancer early, catch all these diseases early, prevent them would be even better, get people to stop smoking. That's all wonderful. But if I don't have the data, I can't do the outreach.
Bruce, you might want to unmute.
That seems to be my habit these
There you
days. Thank you very much. I think the barriers here are really important for people to realize, though I would point out that since we're at something around 2 or 3% take up, there's a lot of room for improvement without precision. I mean, if we got up to 20%, that would still be lousy, but it'd be way better than we are today. But I wanted to call on Jim Mulshine, who's emceeing this whole program, because Jim has been an advocate for the overlap of tobacco illness and in lung cancer screening. Many people get diagnosed with COPD for the first time through lung cancer screening. And I'm wondering if that might be a next step to go the other way, since COPD and lung cancer are both heavily tobacco related. If people with diagnosed COPD are likely candidates for lung cancer screening. And Jim, I wonder if you could comment on that as a way of identifying a population. Again, not perfect, but is it good enough?
Thanks, Bruce. And thank you and all your panelists for coming, because what you're talking about right now is so important. In a sense, it's frustrating to have something that we now see is as good as CT-based screening for lung cancer, and then turn around and find out that it's being used by a relatively small fraction of those that could benefit from that. And that's the case here, but I will point out that, the last numbers I saw was about just before COVID, there was a report that from some kind of analysis that screening uptake in some centers was up to 15%, which compared to the year before, which was about 4%, represents a 300% increase, So, I mean, I think this is moving in the right direction, but certainly the strategies you're outlining could enhance that profoundly. And what Bruce has asked me to address is a conundrum that people don't often appreciate. And that is, you screen 100 people for lung cancer, you find per year 1 lung cancer about. If you look at that same 100 people, based on the information that a panel a little while ago had dredged up and reported, and it has been reproduced across the world, you have somewhere in excess of 35% of that 100 people having some evidence of COPD or something on the spectrum of COPD type of injury from their smoking exposure. And by the way, they also have somewhere between 15 and 20% of them have coronary calcium at some level. And the top level, the top quartile of that, has a risk of a major coronary event over the next 12 months that's 7-fold higher than other smokers, based on MESA's study. So the question is, in a setting like this, where you have lung cancer as the leading cause of death in COPD populations long-term, published now for 3 decades, is there a way to use some of that kind of cross-information in an adaptive way? Because the measures that we talked about that could be implemented today, that is increased physical activity, improved pulmonary toilet, better vaccination, pneumovax vaccination strategies, attention, greater personalized attention to smoking cessation. All those things actually would have impact not only on lung cancer, but on COPD and on heart disease. And it's kind of a unique opportunity for real population health-based, improved outcomes. And so in the way that your strategies work, can that be leveraged?
So let me ask the panel what I asked Jim. So COPD is underdiagnosed, but there's a pretty high diagnosis rate in the especially the Medicare Advantage populations. Given the overlap between COPD and lung cancer risk, would it make sense to target patients with diagnosed COPD and say, make sure that they were smokers or ex-smokers, and to use that as a vehicle for getting people into screening? And I'm going to ask Lisa first, since she had mentioned what a terrible thing it is if a health plan says you need something and you really don't.
No, that might be a way to approach the member screening. I think it always looks better for us if it is in a guideline when we get pushback. So when a member says, well, why are you contacting me about this? And we can say, well, this is in this particular guideline. So if the guidelines were written in a way that we could target folks with COPD, and we could do that, I think that is a way we could get information, and we would have the information a lot easier than smoking and using that. And it's something that we could share with the physicians. Again, we can't put it in our program without it being in the guidelines. We do get pushback for outreach. We get pushback from physicians about including too many things. We can't make up our own measures. We've committed to doing that for several years now. So I think that just saying, well, U.S. Preventive Health Services Task Force recommends this is not enough. There have to be actual guidelines that we're following to say how we're doing it. And that's just the reality of, for everyone who says things are beneficial and things are good, and we may agree with it from a scientific perspective, but we're also the insurance company and the bad guys, and people can take issue with us who are our clients, who can take issue with us for doing things that they don't feel are appropriate. So we have to have very good resources to be able to point to when folks go not just to us and complain, but may go to their employer group or may go to their congressperson and say, hey, this insurance company just wants money. They reached out and told me to have a test and they couldn't tell me where that recommendation was. They're doing it just because they want more money. So that, unfortunately, this is the reality. And I have to say, once I moved into the insurance world, this was an eye-opener for me. But that is something that we deal with. So if there is a recommendation out there, and it does not have to be HEDIS, but there has to be some type of strong recommendation to focus on folks with COPD, then we could potentially do member outreach in that way.
Thank
I
you
agree
very much.
100% with what Lisa said. I mean, I think that a guideline is important, but also really specificity about what it is that we're measuring and why. It doesn't need to just be the what, it needs to be the why as well. So that was well articulated and something that we as a health plan could utilize to go out to providers and members to explain that why we were doing and are recommending certain things. I think that the one thing that we sometimes don't give enough, weight to is that there's oftentimes suspicion, right, from members, as to why we're asking them to do what they're doing. They're concerned oftentimes that it's going to lead to non-coverage, right? It's going to somehow lead to us going ahead and saying we're not going to do certain things for them. So there needs to be clear evidence that these are recommendations from a reputable group that is 100% in agreement that this is the right thing to do. NCQA has a tremendous amount of clout in this. So NCQA's standardized measurement, going ahead and making sure that all health plans are measuring it in the same way, identifying their members in the same way, moves mountains in terms of the ability for us to really go out there and make, impressionable change with our delivery system as well as our members. So I think I'm just reiterating everything that Lisa said, but I think that the physicians here and everyone on that and who are really invested in this, you need to pursue that path, right? You really got to get this at the attention of NCQA and move it forward and get their attention, and you'll get our attention as a result of that. Absolutely.
And I just add something more as a layperson than anything else, and listening to this conversation, is that seems to this whole, it's a couple of things I've heard is that it's hard to do this in isolation of the care that the person's getting, which is one of the reasons I think the conversation about a primary care physician, but particularly around a smoking related disease. And it's not, lung cancer may not be smoking related. Father-in-law who died of lung cancer, non-smoker lung cancer, which seemed really unfair. And he was not a coal miner either. But it's, the fact is that I think it's probably pretty sensitive for people who are smokers to be also not wanting to be accused, and they might already have COPD and still be a smoker, or have asthma and already still be a smoker. This is a tough area to tackle, and then to suggest you're going to have is a non-invasive procedure, but it seems to have to be done in a way that creates some context for patients, which is why the measurement is one way to do this. But it seems like a just much larger issue to engage both beneficiaries and providers who all know, I'm sure, when they see a patient who's a heavy smoker, the path this patient could be on. And so it's partly about the measurement. I think that would help, but it is also about the education to providers and patients and beneficiaries that their role in this as well. And that they need to understand the risks they're at. Maybe getting a lung cancer screening would help them understand the risks they're at. But that's still not an easy. It's not a brief or easy conversation, and it has to come from someone who's a trusted source.
Well, I just wanted to interject one thing real quick, if I may. I talked about the 6 Ps of the stakeholders, and I think I did want to bring in the purchasers, because I do work, I am one of the medical directors of the National Alliance, and with purchasers, we've really focused on commercial and Medicare so far, and Medicaid, so government and commercial payers, but there's also self-insured corporations, and they're large corporations that do run their practices through third parties as well. And again, we're talking billion-dollar spends. And a lot of the people that are head of the benefits programs at these billion-dollar corporations sort of bubble their way up through HR. They really don't have a medical background. And when employees that work for large companies are at times concerned about their benefits because they think, well, my employer's trying to ration or reduce my benefits because, we know that GM for a while spent more on healthcare than it did on steel. So obviously it's a large spend. But from a purchaser standpoint, I just wanted to make just a couple of comments, and that is, purchasers are not trying to reduce healthcare services. They are more than willing to provide the covered services so long as those services are appropriate. So anytime that we can have specific guidelines, and anytime that we can have a measure such as this, which is going to provide a more healthy workforce for large employers, that is going to ensure a more healthy workforce, which is going to increase their productivity, and there is a win-win for everyone involved. Secondly, purchasers are willing to pay more for certain healthcare services, but if they do pay a premium, they want to know exactly what that value add is. And especially now in the pandemic, anytime right now that an employee knows that their employer is willing to spend money for preventative services, that helps build a relationship between the employee and the employer. So from a purchaser standpoint, if this type of lung cancer screening into a HEDIS criteria.
Well, thank you very much. I think you're, Suresh, I'm very glad you brought in the huge self-insured employers that frankly cover more than anybody else of the U.S. population. So that's a critical element to this discussion. We're at the end of our hour. I wanted to see if I could call on Congresswoman Schwartz just to one last question, which is about politics and government, and not about the election, but what role do you see for the government in this kind of issue? Here's a group that's very concerned with lung cancer and other related illnesses and the technology advances and population health. Everything we've been talking about has not everything, but most of it has been what organizations can do, what the insurers can do. What can we expect from the government?
Well, I think that we start with these measures are done through mostly through government programs. I think hearing all that we did this afternoon is certainly important for policymakers. That includes members of Congress, honestly, who may or may not understand all the minutiae we just talked about for the last few hours. But they have advocates coming all the time to say, here's the things we need. It could be on on the American Association, the Lung Cancer Association, that says one of the issues we want in our laundry list of issues is one that we want to make sure that quality measurements align and there's attention to this issue of measurement. Again, I think it probably works well to be a part of a broader conversation about, what maybe we got tired of talking about tobacco, but we shouldn't be. I mean, this is a huge issue that tobacco use is still, if anything, I think I understand it growing for young people again. That's pretty scary because that's when people start the tobacco use. So it's the real risk factors, and to understand that this is part of the agenda is to make sure that then insurers and providers and regular folks understand these risks and take advantage of the screening and prevention and healthcare services that can help them avoid a really difficult illness and going forward. So I think this is important. Policymakers always matter. Talking to your member of Congress about what you care about is always matters. And sometimes, yes, you do need some champions in Congress to be willing to say, this is my issue, and I want you to do all that you can, and here are the things you can do to CMS. And they do have, they do conduct. They do take that seriously. This administration just did a major initiative in a variety of different ways around kidney care and end-stage renal disease, people on dialysis. This is, again, the incidence in this country is 500,000 people. That's not small, but it's not everyone. But they're extremely sick and complex patients, and are so for many, many years. And so I think that's sort of interesting. I mean, why did they particularly take on kidney disease this year? Well, I can give you some reasons, but I pretty much all of the stakeholders understand that this is serious and needs to be attended to. And it's again, I think it's an example, but it's one that it's important as we go forward to understand that lung disease too is something that is potentially preventable, and it certainly can be treated. It's treatable, particularly if you get it early, and it's part of the whole cancer discussion as well. But you heard it at COPD. Their cardiac issues. The attention. I'll end with this: the attention to those who have chronic conditions and the need to intervene earlier and more consistently in order to help them manage their chronic disease and slow the disease progression is a huge challenge before us in this nation. And we need to do it with attention to health disparities and social risk factors. And it's one that we could tackle as a nation, and we should. So I think we're trying to do that in fits and starts. And of course, I work on Medicare Advantage. I think an integrated care system that takes the long view on patient care and really does incentivize quality and value is a huge step forward. But overall, we tend to think about healthcare as episodes of care. And when you're really looking at what's going to really help make sure that Americans are healthier is actually the attention to chronic illnesses and slowing that disease progression. So that's my public policy answer. And it's one that really takes a lot of people working together to make it happen.
Well, thank you very much, Congresswoman, for your comments. I can't hope to do a summary as elegant as yours. So, but I do want to thank all our panelists from the first panel that set up the lively conversation in the second panel. So, I really want to thank you all for bringing your insights and your lively views and energy to this session. And I'm always I was teasing Jim Mulshine that he always seems to give me the graveyard presentation, the last presentation on the last day. I don't think that's such a bad thing in a virtual conference, actually. So, Jim, thank you for this opportunity, and I think I hand the virtual microphone back to you.
Bruce, thank you. Thank you very much. And I must say, this is actually the most optimistic health policy discussion I've ever attended. So Bruce, thank you and all your colleagues for really suggesting some very important and productive ways forward. Because Congressman Schwartz, I think there is real value from a chronic health dimension to the types of approaches we're talking about. And it's an integration of high technology, computer sciences, and respecting people that's coming together in the kind of care paths that we're talking about evolving. So it's very important. I'm very, very respectful of time, and I'm sorry we ran just a bit over, but I wanted to thank everyone who was associated with helping us have these last 3 days of conversation in this very important space. I want to thank the Prevent Cancer Foundation, who has been our steadfast supporters over the last 17 years in these efforts. I want to thank the American Lung Association that stepped up and helped us partner to bring this all forward. We've had many other sponsors. We don't have time to name them all, but we profoundly appreciate their support. The faculty who put this together have done enormous amount of work in the background to try to distill and integrate what they were going to discuss with you over the last 3 days, and really make an effort to make it interactive and bring in the voice of the people participating via Zoom technology. And it's interesting, we had trepidations, but I think by and large, our very, very talented technical staff has helped us see our way through all that. And we've had quite a fertile discussion that is going to require us to kind of go back and rethink how we can combine and collaborate to bring forward these suggestions and kind of follow the admonitions that the good Congresswoman just shared with us, and thinking about really making this a healthier community and really being an example to the world that we can have a positive impact on chronic diseases if the medical community and the community at large, individuals, work together to bring forward a variety of societal influences in terms of diet and lifestyle, and hopefully augment that with our ever burgeoning molecular diagnostic and therapeutic capabilities, and bring it together in an organized way using the wonders of artificial intelligence. It's not going to be easy, and it's not going to happen tomorrow, but we're on a process that is very important. So I'd say one last thing. We've had some very, very hardworking staff with the Prevent Cancer Foundation who have helped us in terms of coordinating everybody getting to us and overcoming whatever Zoom gaps and stuff like that. I don't know how we give them a round of applause anymore, because that seems to be anachronistic, but we have a virtual round of applause for our virtual assistants. And with that, unless, Bo, you wanted to say any words?
Just quickly, I'd like to thank everybody who came in here with Charlottesville. No. I've got a mic, okay, sorry about that. I was launching into my spiel without having a mic in front of me. No, I just want to close with thanking the panel. This was a very stimulating panel, and it kept everybody awake for the very last session. So bravo. Thank Jim for his leadership of this effort for 17 years. It's just been amazing to watch his mind work and keep thinking of new things to talk about. And then finally, Liz Hall and Stacy and Haley and everybody from the foundation, Adrian, you've all just done a wonderful job. And thank you so much. And thank you, team from Blue Ridge. You've just done a super job. And I would say it was as close to flawless as a virtual conference can get. So we really appreciate it. And now I will turn it back to Jim to close.
We're closing. A nice thing about Zoom type meetings like this is everybody has a safe trip home. So thank you all, and we'll keep talking and we'll be in touch. Have a great weekend.